Hi, now we're looking at chapter 32, care of patients with non-infectious lower respiratory problems. Okay, the first thing that we're going to talk about is asthma, the impact of asthma on healthcare in the United States. And the next couple of slides that you will see is just some statistics that came from Asthma and Allergy Foundation of America and American Academy of Allergy and Asthma Immunology. So I'm not going to read that word for word, so you will see the next one shortly here. Here's the prevalence of asthma in the United States. Again, it's estimated about 8.4% Americans are affected with this. And you have to understand, this is probably about 4 years old information. The way it looks now, it's probably higher this time around. So slightly more prevalent among African Americans than Caucasians, and number of people with asthma continues to grow every day. More statistics. That's the cost of asthma to treat asthma in the United States. Okay, asthma again, condition that occurs intermittently, and it can occur in two different ways. One is in inflammation, and two, airway hyperresponsiveness leading to bronchoconstriction. Okay, let's look at the pathophysiology. There's the two kinds that we just mentioned, the intermittent and reversible airflow, and also the airway obstruction that causes the inflammation. Okay, continuing on the pathophysiology of asthma. This picture depicts a comparison of a normal bronchial tube and a bronchial tube during an asthma episode. So asthma is characterized by three things. You have your bronchospasm, there's an increased mucus secretion, and you have a mucosal edema. If you combine those three things, you end up with obstruction. And also there's two types. You have your extrinsic asthma, which is caused by outside factors like pollen, dust, anything environment like that. Also, the second type is the intrinsic asthma, which occurs after severe respiratory tract infection. Okay, so if you look at the different the effects of it, I don't know if you remember, we talked about how the body responds to allergic reaction, and there's several things that's going on. Once the body is exposed to allergen, okay, allergen. Inflammation is triggered, okay, and after inflammation, then you have leukocytes production, which are white blood cells, leukocytes, and then that leukocytes triggers the plasma cells, or turns into a plasma B cells, and which in turn it's IgE, okay, so the IgE, you put that IgE, again it's an antibody, is responsible for triggering the mast cell. And what do we know about mast cell? They produce histamine, prostaglandin, SRSA, and we are going to talk about this. And so the way these three things, the histamine, prostaglandin, and SRS, works. So when histamine attached to the receptor site, it causes that inflammation that we just talked about. The slow reacting substance of anaphylaxis, also known as SRSA, attaches to the receptor site in the small bronchi, causing the swelling of the smooth muscle, which on top of that, the SRSA causes the prostaglandins to travel to the lungs, where it enhances the histamine effect. When histamine hits the mucous membrane in the bronchi, it encourages the mucous membrane, or stimulates the mucous membrane to secrete excessive mucus, which further narrowing the bronchial lumens. Therefore, that is your increased mucus secretion. So once the mucus fills the lung bases, inhibiting the alveoli ventilation, then the blood gets shunted to alveoli in another lung parts, which means there's a decreased ventilation and increased perfusion, that means shunting happens. This is where that shunting, that VQ that we talked about the last time. So when ventilation is decreased, then the CO2 initially would decrease. However, later on, it will be increased. That causes acidotic state, and then of course the oxygen saturation will drop. Okay. Okay, the next thing is we're going to look at the causes of it. We kind of mentioned about this already. Again, the different types based on how attacks are triggered. And if you can see, if you look at the picture, you have the environment, you have the external and internal causes, you have the pollutants, allergic substance, and often drugs. And the most common one in healthcare is actually antibiotics. So if you look at this, again, it's caused by specific allergens and general irritants in the irritants in microorganisms. And hyperresponsiveness is caused by exercise, upper respiratory infection, and for other unknown reasons. Okay, so I guess remember that our body reacts with allergens, as you can see in here. You have the environment. You have the environment itself, the humidity, air pressure, change in temperature, and work and exercise. And then, of course, any for pollutants, if you look at the pollutants, there's actually an extrinsic allergen that causes the inflammation and that triggers the leukocytes. And that leukocytes then produces us plasma cells, specifically the IgE. And the IgE triggers the mast cells to produce your chemical mediators, the things that causes the inflammation and increase mucus production. Those are your histamine, prostaglandin, SRSA, like I mentioned earlier, serotonin, and cytokines. So those are some of the corporates, some of the things that causes all that. And histamine itself, remember, like I mentioned earlier, it encourages the mucosal lining to produce more mucus. And remember, as a part of the asthma patho, increased bronchospasm, increased mucus, which inflames or it makes the mucosal swell up or becomes edematous. If you put those three combined together, you're going to end up with obstruction. And that, again, that's the main thing that happened with asthma. Okay. Collaborative management, of course, you're going to do some assessment, and a lot of these things that the common things that you would hear with asthma, if there's a narrowing, of course, wheezes, okay, sometimes stridor. You do physical assessment, clinical manifestation, like I mentioned, increased respiratory rate, audible wheezes. There's coughing because your body tends to try to get that extra mucus out of there. They use a lot of their accessory muscles. They have barrel chest from air trapping, long breathing cycles, and it's sometimes not uncommon to see some cyanotic skin coloration and hypoxemia. Some of the laboratory assessment that you would do, arterial blood gases. So if you have a patient that is going into asthma, of course there's increased CO2 retention and not enough oxygen. So as a result, you're probably going to end up with a respiratory acidosis, right? So arterial oxygen may decrease in acute asthma attack. Then again, CO2 may decrease in early attack and increase later, indicating poor gas exchange, because your body is going to give up somehow, sometimes. So very important that you keep that in mind. So we have to treat it fast. Other things that you're going to see, there's an allergic asthma. If you check the blood levels, you're going to end up with eosinophil, and also your IgE or immunoglobulin levels with the specific of E. Sputum with eosinophils, mucus plugs with shed, those are all indicative that there's been an allergic reaction. Okay, for pulmonary function test, this is the test that accurately check their lung volume capacity, also the flow rates, diffusion capacity, and gas exchange. And also they also use this to check for if there's any airway resistance. So this is done in more controlled environment, there's machine that they use for this. As far as intervention, teaching for self-management, patients with asthma really require some extensive education about how to do maintenance and also what to do in cases of emergency. They would teach them how to use peak flow meter twice daily, fastest airflow rate reached at any time during exhalation. So that's one of the things that we measure. And of course, there is a you have to look at the picture. It's in the book. It shows you what it means to be in a red, green, and yellow. Also, for personal drug therapy plan, you need to see chart 32.6, and that kind of give you some detailed information as far as intervention as well. For quick relief medication, I think this is also depicted in the next slide, but beta-2 adrenergic agonist, albuterol, is what we use for quick relief. And then, of course, for drying effect, we have an anticholinergic medication called Atrovent. Some of the long-acting medications that we give is corticosteroids and long-acting beta-2 and leukotriene modifiers, which helps with decrease that leukotriene. It's one of those chemical mediators. Okay. So again, as far as teaching for self-management, good understanding how drugs work, when to use it, and what medication needs to be used based on their symptoms. And as a nurse, you need to encourage them to create an action plan, making sure that they're meeting if they see the personal triggers, and what kind of responses that they would do without those triggers. This cartoon depicts like a summary of how you're going to manage the asthma. Adrenergics, like I said, we're going to mention how all of these works later on. Beta-2 agonist and albuterol, which is again, it's one of those rescue inhalers. They give them steroids to help decrease the inflammation. Same thing with theophylline, hydration, and oxygen as needed, of course, and some anticholinergics, and those are your drying effects. Medication that has drying effects, which means your mucus is what they're trying to dry here. This particular slide actually depicts all the stuff that we talked about so far. So it's shows you the triggers, it shows you the manifestation, clinical manifestation, and also the two emergencies that we're going to be talking about here as well. So some of the triggers, hypersensitivity to anything like allergic reaction to something. If you have a patient that has a history of asthma that just happened to develop some upper respiratory infection, that is a trigger that causes them to have an exacerbation of asthma. Exercise is the same way, and also GERD, that a GI disorder that we're going to talk about later on. Some of the things that you would see have symptoms of coughing, increased mucus, shortness of breath, all of those things that are indicated there. Some emergency, if symptoms do not respond to usual treatment in 30 minutes after an attack, you need to tell your patient that they need to seek medical attention, and that could lead to a status asthmaticus that is life-threatening. Okay, so as far as drug therapy, again, the specifics about this particular drugs will be discussed later on. So when you're looking at the drug therapy, it's based on the severity and the treatment. So you have preventative and you have the rescue drugs. So your preventative is something that you could use every day, regardless of symptoms. And of course, the rescue drug is actually when there is an attack. And for this, we have the beta-2 adrenergic, which is also known as albuterol. So, okay. So again, as far as the drug therapy, there's different kinds. You have your bronchodilators and you have your anti-inflammatory agents. So those are I'm giving you guys just a